Our next speaker is Aimee Kreimer from the United States NCI. She's going to present an evaluation of HPV antibodies and risk of subsequent head and neck cancer.
Hi. I have no conflict of interest to declare. We wanted to prospectively investigate HPV serologic antibodies and risk of subsequent development of head and neck cancer. To do so, we nested our study within the European Prospective Investigation into Cancer and Nutrition, or the EPIC study, where 400,000 participants from 10 countries gave a blood sample in the 1990s. These individuals were followed up for subsequent health events with a focus on cancer. We nested a case control study within EPIC, comparing head and neck cancer cases with cancer-free controls. Our cases were defined as incident cancer of the oral cavity, oropharynx, or larynx, and all cases had to have a pre-diagnostic blood sample collected. Our controls were individually matched on age, gender, and country in a 2-to-1 ratio. HPV serologic testing was conducted by Dr. Michael Paulita at DKFZ. We looked at HPV-L1 for 14 HPV genotypes, the majority of which were carcinogenic. In addition, we looked at HPV-E6 and E7 for 10 genotypes, and we looked at HPV-E1, E2, and E4, which are regulatory proteins for HPV-16 and 18. Now, our true focus was on HPV-16 because we know that the majority of HPV-associated head and neck cancers are driven by HPV-16. And we also focused on HPV-E6 and E7 because these are the oncoproteins. And in fact, theoretically, if a cancer is driven by HPV, there should be antibody presence to these proteins. And in fact, multiple case control studies have validated this hypothesis. However, no prospective data has been available until this point. We had HPV serologic data on 638 cases and 1,599 comparable controls. Our cases included 180 cases of oral cavity cancer, 135 cases of oropharynx cancer, and 247 laryngeal cancers. Among these cases, the median time from the blood draw to the subsequent diagnosis of the cancer was 6.5 years, with a range of about 1 month to 13.9 years. As I said, our main focus was on HPV-16. Here I'm showing you our results for the E6 seroprevalence and head and neck cancer risk. So the prevalence of the HPV-16 E6 antibody response among our 1,599 controls was quite rare. 0.6% or 9 individuals without cancer had this antibody. Among cases of oral cavity cancer and larynx cancer, again, HPV-16 E6 seroprevalence was quite low at around 1%. However, among cases of oropharyngeal cancer, 1/3 of the 135 cancers had HPV-16 E6 seropositivity. This resulted, when we compared our oropharynx cases to the controls, in an odds ratio of 274, and this was after adjustment for matching variables as well as tobacco and alcohol use. Because of the strong signal for the oropharynx cancers, we expanded to look at the markers, the other proteins for HPV-16. I showed you already our results for HPV-16 E6, where we saw the very large odds ratio comparing controls and cases. When we looked at all the other proteins, including E7, E1, E2, and L1, we noticed significantly increased odds ratios. E4 was the exception. I'm going to dive a little bit deeper into our finding with the HPV-16 E6 antibody because not only was it present in a high proportion of the cases, relatively high 1/3, it was also nearly absent in the controls. So we went on to look at the time between the blood draw and the cancer diagnosis, and we grouped this in categories of less than 2 years, 2 to 5 years, 5 to 10 years, and more than 10 years. And then we looked at the HPV-16 E6 seroprevalence, and this is restricted to the positive oropharyngeal cases. What we expected to observe was that in blood samples that had a very short interval between the time of collection and then the subsequent diagnosis of cancer, there would be a high seroprevalence of our antibody marker. And then in the samples that had a very long time, more than 10 years, it would be much lower. This is not what was observed in the data. In fact, we saw no temporal trend associated with HPV-16 seropositivity and time. So in their samples that were collected had a longer duration of time between specimen collection and diagnosis of cancer, specifically 5 to 10 years and more than 10 years, we still saw that 1/3 of our cases had HPV-16 seropositivity. This shows the robustness of this marker. In this slide, I'm going on to show you the antibody titer levels among all individuals who are HPV-16 E6 seropositive. And I'm restricting among here, these are the oropharynx cases, and I'm again showing you in these time intervals. And I've included the 9 controls who are HPV-16 E6 seropositive. And what we saw is that there was a non-significant decline in the antibody titer level among increasing time between blood draw and diagnosis of cancer. However, this was not only well above, note that this is on a log scale, this is well above what was observed in the seropositive controls, and was also well above the cut point for seropositivity, which was pre-specified prior to looking at the data. So here we see this cut point for positivity in red, and we see that all the oropharynx E6 seropositive cases had very high antibody titers. We also went on to see if this marker, the HPV-16 E6 seropositivity, could prognosticate, as has been observed with HPV DNA in tumors. And in fact, what we saw is that individuals who had the HPV-16 E6 seropositivity among the oropharynx cancer cases, shown here in red, had significantly better survival at 5 years. Theirs was 83% compared to the HPV-16 E6 negative, whose was at 5 years about 60%. In summary, HPV-16 E6 seropositivity was present more than 10 years prior to diagnosis of oropharyngeal cases and was nearly absent in controls. Thus, our data suggests that HPV-16 E6 seropositivity holds promise for identifying oropharyngeal cases prior to diagnosis. No associations were observed for oral cavity or larynx cancer. Now, why is this? Why is this signal showing up for the oropharynx cases? And in fact, in the cervical cancer literature, we haven't seen much signal there either. We know that the tonsils are lymphoid organs, and it may be that immune presentation of infections at the tonsil may induce HPV-16 E6 seroconversion. So while previously we thought that antibodies against HPV E6 and E7 were markers of invasive disease, it may well be that at the tonsil they're actually marking a persistent infection that has a high likelihood of progressing to cancer. There are important unknowns in our data. Specifically, we're unable to quantify the sensitivity of the HPV-16 E6 marker because as of yet we do not have the tumor samples, so we cannot estimate which tumors are driven by HPV. In addition, we don't know the true lead time between production of HPV-16 antibodies and the development of cancer. In the EPIC study, we observed that in the longest available intervals, there was antibody presence. So, for example, we had one individual whose blood draw occurred nearly 14 years prior to diagnosis of cancer, and in fact, that person was robustly HPV-16 E6 seropositive. We are moving in future directions to validate our serology findings in other cohort studies. In addition, we're working to obtain some of the EPIC tumor samples so that we can evaluate both HPV DNA as well as other HPV markers in these tumors. We're looking to expand our evaluation of HPV-16 E6 serology to other anogenital cancers in EPIC to really understand the specificity of this marker. Is this really a tonsillar or an oropharynx-specific biomarker, or might it work for other HPV-associated cancers? And finally, we're going to evaluate HPV-16 E6 serology among healthy individuals with known oral HPV infections, and this is actually going to be in the HIM cohort, because if we do do believe that this marker may in fact be marking oral HPV persistence, we might be able to get a better understanding in healthy people. Thank you.
Go ahead.
Why there's such a difference between E6 and E7 in prostate cancer, both in terms of percentage of antibody and hazard ratio?
Yeah, that's a good question. We think that's actually an artifact of the assay. We did see a significant elevation in the oropharynx cancers for E7, but we also saw a very high proportion of the controls. We saw 10% of the controls seroconverting, so it doesn't make it a possible biomarker, so we didn't focus really on that once we saw. But we've also gone on, I didn't show here, to do combinations or algorithms of positivity against multiple proteins. And most of the ones that were E6 positive were also E7 positive. Yes, Howard?
Congratulations, Aimee. Very exciting.
Thank you.
Given the low background rate of the E6 antibody, and the strong associations that you're seeing, I'm wondering if one explanation for the data might be a tumor, or early lesions that are undetected, present with long latency. And given these results, whether a way to evaluate that might be to do brush biopsies of E6 positive patients, and given the fact that, you have these, the low background, I think you'd be justified.
I think it's part of what we're pursuing now. These were surprising results and for us, and now we're working to identify, what would be the next steps, because exactly as you're saying, we can't just find that someone's at risk and then what? And so I think we need to identify then, where the tumor is and, kind of the next subsequent steps, and that is a good suggestion. So thank you.
Aimee? Given the strong association between E6 and the development of head and neck cancer, shouldn't be ethically recommendable, advisable to see what happened with the control women or subjects that are E6 positive but didn't develop head and neck cancer, whether they develop other anogenital cancers? Or
That's a very good question. In fact, one of the things that I didn't mention that we found very curious was that of the 9 controls that we did find HPV-16 E6 seropositive, one, we did look to see if they had additional cancers, and in fact, one did have an anal cancer, which is one of the reasons that we're now going back to EPIC to redo this study at the other anogenital sites. I think you raise a really good point, and I will take it back to my collaborators and ask them about the other 8 controls.